Hello and welcome back. So the initial slides I'm going to repeat because I noted that the previous recording was not good. So in the menstrual, the cycle, there may be ovulation or periods may happen even without ovulation. So it can be ovulatory cycle or it can be anovulatory cycle. And how do we know that whether a person is having ovulatory bleeding, like whether she has had ovulation in the middle of the month, or is she having bleeding without ovulation? Actually, yes, we have objective tests, like we can, if it's a 28-day menstrual period, we can check the most reliable test to assess ovulation, whether ovulation happened around mid-cycle, that's serum progesterone levels. Okay, so we can do a serum progesterone level if it's a 28-day cycle, so we have to do it on day 21. But if it's, for example, if a 30-day cycle, then we have to perform a serum progesterone level, so just subtract 7, we will do it on day 23. Okay, so that's the confirmatory test. But even in history, sometimes we know that we can kind of guess whether a patient is having ovulatory cycles or anovulatory. First is ovulatory cycles, they have dysmenorrhea. Okay, so they have pain. However, please note that when we say a patient is having dysmenorrhea, there are two types of dysmenorrhea: primary and secondary. Okay, so primary is normal. Primary dysmenorrhea is associated with ovulatory cycles. Okay, and secondary dysmenorrhea, that's pathological, that's because of some diseases or conditions. Okay, so how do we differentiate whether she is having a primary dysmenorrhea or secondary dysmenorrhea? Is the pain differing in primary dysmenorrhea, that's bearable, like that's not too much, and usually it responds to over-the-counter, for example, NSAIDs. Like if you give patient ibuprofen or mefenamic acid, patient usually responds to them. It's not severe enough to miss their school or stay in bed during the all days of the period. Okay, so secondary dysmenorrhea, it's a lot of pain. They usually do not respond to ordinary painkillers. Most of them, they need hormonal treatment. Okay, again, in history, how do we know whether it's primary or secondary dysmenorrhea? So in primary dysmenorrhea usually starts a day, usually like sometime before actual starting of the period, and it usually gets better over the days of the period. Okay, so by day 3, 4, it's usually done, it's gone. In secondary dysmenorrhea, it starts after the period start and it gets worse over the days of the period. Okay, so that's secondary dysmenorrhea. Now, what is the cause of primary dysmenorrhea? It's physiological, it's kind of a normal process, but why does it happen? It's because of the prostaglandin F2 alpha in the endometrium. Okay, so that's a normal physiological thing. And why does secondary dysmenorrhea happen? Secondary dysmenorrhea is mainly big. There is a long list, but at least you should name at least 3 conditions. First is always think about endometriosis. Second is adenomyosis. Third is pelvic inflammatory disease. Okay, and sometimes it may be because of intrauterine copper device, but at least remember the top 3 reasons. Okay, we have separate lectures on these conditions, so we won't go into those details. Also, ovulatory primary dysmenorrhea is usually associated with nausea. Okay, but that's not a hard and fast rule, but usually. Okay, so the ovulatory bleeding, and then we have anovulatory bleeding. So the periods where there is no ovulation, which conditions cause it, right? So there is actually a long list, but sometimes it can be physiological. For example, the extremes of reproductive age. For example, when it's a teenage girl, 15, 14, 16, maybe her hypothalamus pituitary ovarian axis is not mature yet, right? So, and as a result, the ovulation does not happen, and so it takes some time for this HPO, hypothalamic pituitary ovarian axis, to become mature. Okay, and again towards the other extreme of the reproductive age, which is close to the perimenopause. Okay, and then sometimes in these periods, maybe the pattern may be very different. Like they may be irregular, they may be sometimes prolonged periods, sometimes they may be heavy, sometimes they may be light. Okay, we have to rule out certain conditions, especially in this part of the region. We have to always rule out polycystic ovarian syndrome. Okay, it's quite a common condition, but then there are some other endocrinological problems which I'm going to discuss in the next slide. So the cause of anovulatory bleeding may be anything from like extreme reproductive age to endocrinological problems, or sometimes it may be because of something sinister. Okay. Usually, why it happens. So basically, when there is no ovulation, remember we talked about corpus luteum and which secretes progesterone. So if is no ovulation, there is no corpus luteum, there is no progesterone. As a result, there is only estrogen, right? Unsupported by progesterone, endometrium, which had enough estrogen, but it is not supported by progesterone. So there is irregular shedding of the endometrium. Okay. Now, what are the causes, right? So in endocrinopathies, yes, polycystic ovarian syndrome, it can be hypothyroidism, but remember that although hypothyroidism is more common, hyperthyroidism can also cause ovulatory dysfunction, okay? And then there may be hyperprolactinemia, even if a woman loses a lot of weight, okay? For example, if she has anorexia, or if she is, say, for example, an elite athlete or a ballet dancer, and because of her professional preferences, if she loses a lot of weight, even that can affect her periods. Why? Because see, hypothalamus controls, it releases gonadotropin releasing hormone, right? And this GnRH ultimately goes to the acts on the pituitary, from where follicle stimulating hormone and luteinizing hormone is released, which then act upon the ovaries and which releases estrogen and progesterone, and that acts on the endometrium, right? And they have negative feedback effects. So if there is any problem in this intricate balance, there can be irregularity or absence or abnormality of the bleeding, which is called abnormal uterine bleeding. Sometimes it may be because of the doctor, right, or the healthcare professional. Maybe they just prescribed some medication which may not be related to gynecological thing, right? See, for example, it can be steroid intake or any medication which affects dopamine metabolism, for example, related to psychiatry, right? Tricyclic antidepressants or phenothiazines, or even a common medication is spironolactone, right? So the woman may not be taking it for gynecological purposes, but it may be causing. So that's why it's important to take a detailed history. Okay. So now, how do we classify the causes of abnormal uterine bleeding? This is called FIGO staging. FIGO is the International Federation for Obstetricians and Gynecologists. I think it's in Italian, so that's why like F comes first, Federation International, something like that. It's for premenopausal women, this classification. And the mnemonic is palm coin. Okay, P stands for polyp. It can be an endometrial polyp, it can be a cervical polyp. Then A stands for adenomyosis. L stands for leiomyoma, which is another name for fibroids. M for malignancy. Now, this malignancy can be in the endometrium, it can be in the cervix, it can be even ovary. Okay, because ovaries can also, there are different types of cysts, right? And some of them may be estrogen secreting ovarian tumors, okay, like granulosa cell tumors. Okay, then non-structural causes. So these PALM, PALM, this mnemonic, it's because of the organic causes, and then the non-structural causes or non-organic. Coin is COEIN. Okay, C stands for coagulopathy, which means the woman may have some coagulation problem. Now, it can be even because of a problem with the coagulation factor, or it may be problem with the platelet function or even number. Okay, so for example, with platelet function disorders, there is a condition which is called Glanzmann thrombocythemia. Okay, Glanzmann thrombocythemia. Okay, and even women who have hemophilia, who are hemophilic carriers, right? Women do not have the disease hemophilia, but they are carriers, they transmit it to their sons. So even these women who are hemophilic carriers, they can have heavy bleeding or they can have postpartum hemorrhage. Okay. Then O stands for ovulation. So all of the causes which we discussed in the previous slide, or any problem with the ovulation, so they can cause problems with abnormal uterine bleeding. Endometrial. Now, this endometrial, apart from malignancy, it can be even an infection, like, for example, any infection which, for example, affects the endometrium, like, for example, tuberculosis. Okay, so tuberculosis can even affect the fallopian tubes and the endometrium, right? So, and it's one of the common cause, not common, but it's a known cause of infertility in countries where tuberculosis is common. Then iatrogenic, as we discussed, because of medications, and N stands for not otherwise classified. So not otherwise classified means ishmocele. So usually ishmocele is, so if in this picture, this is an ultrasound scan of of a uterus where most likely it had a cesarean section, right? So in the lower segment of the uterus, in the anterior wall, there was some surgical procedure, most likely a C-section. And see if after C-section, if a woman has had poor healing because of infection or some reason, right? Most likely infection, just poor healing. Later on, there can be a gap which is called ishmocele, and this can be one of the causes of abnormal uterine bleeding later on. Okay, so how do these women present with abnormal uterine bleeding? They can present in different ways. The most common one is usually heavy menstrual bleeding. We used to call this condition menorrhagia. Even in clinical practice, we still use this word, but when you are in exam or when you are being assessed, it's better to use this word HMB, heavy menstrual bleeding, rather than saying menorrhagia. Okay. What exactly it is, as the name suggests, it's the excessive menstrual bleeding. Okay, so if a woman is having, so we are talking about the volume. Okay, volume of period. Yeah, the list of conditions which may cause heavy menstrual bleeding is long, but we always have to rule out a few conditions, especially. Is it endometrial hyperplasia? Is it fibroids? Fibroids are actually 30% of heavy menstrual bleeding. Okay, and is it adenomyosis? Now each patient is different. That's why we have to take a detailed history focused on that patient, because we have to see adenomyosis is usually in middle-aged women, right? So if it's a very young girl, she's least likely to have adenomyosis. Okay, so like we have to take overall clinical picture of that patient. The second type of abnormal uterine bleeding is intermenstrual bleeding. Intermenstrual bleeding means, yes, the woman is having, say, for example, 2 periods, but she is having bleeding in between. Okay, so it may be like 2 or 3 times periods, a little bit of bleeding in between. That's intermenstrual bleeding. Okay, previously we used to call it metorrhagia. Now this term is obsolete. So again, with this condition, whenever there is intermenstrual bleeding, we always have to rule out a few conditions, especially it can be a polyp. Now where this polyp can be, it can be in the endometrium or it can be in the cervix. Okay, and then we have to look for other benign conditions of the cervix, ovary, uterus, and endometriosis, but we always rule out polyps. And especially if the woman is having heavy menstrual bleeding with intermenstrual bleeding, and depending on her age, especially more than 40, we always have to rule out endometrial hyperplasia and cancer of the endometrium. Okay. The next pattern of abnormal uterine bleeding may be post-coital bleeding, as the name suggests. So it is related to intercourse. So if a patient comes to us saying that she has noted some bleeding after having sex, it can be just 1 spot, 2 spot, a little bit of bleeding, but we always rule out cervical pathology. So yes, it can be even physiological, like it can be a cervical ectropion, but it can be cervical cancer or precancerous condition of the cervix. Okay, so postcoital bleeding, always rule out cervical pathology. Then post-menopausal bleeding. Now, menopause actually means it has been at least 1 year since the woman's last period. So after menopause, after reaching menopause, if a woman presents with even a little bit of spotting, it does not need to be heavy bleeding. Okay, even if a woman, say for example 55 or 60 years of age, She comes with a little bit of bleeding, and if she has reached menopause, it's called postmenopausal bleeding. In postmenopausal bleeding, yes, we know that 70% of them, they have benign conditions, but always 10% the chance that she can have endometrial hyperplasia and endometrial cancer.